Thank you, Madam Chair, and thank you to our panel. I represent a vast, sprawling district in Arizona that's very rural. And for over 20 years of my private law practice, I represented the regional hospital and many physicians groups, including our emergency physician group. So I thank you for being here. Healthcare reform and provision in rural areas is very, very important to me. My first question is for Dr. Heyman and Dr. Prescott regarding the SGR being tied to the GDP. And I'd like to know if there are other factors that you think would provide a more accurate baseline. So maybe you start with Dr. Prescott and then go to Dr. Heyman.
Well, I hope there are other factors that provide a more accurate baseline. My life, my expenses, my house payments, they don't follow the GDP. They seem to follow some other issue that might be related to consumer price index. I don't want to belittle the complexity of the math, but I just have to say there's one thing we've proven, tying it to the SGR and how that relates to the GDP just isn't taking care of the process. It's not keeping up with any form of expense increase. What we pay our employees in these small businesses, there's no way a single parent could have a job and be employed in a practice that followed the variation in salary if it followed the SGR. I think establishing a fixed base, as the President has recommended, is a place to start. But of course that still means we have to fix the formula. I'm not giving you a direct answer, but we know that the current system is so incredibly broken that it's harming people.
Yes. Dr. Heyman, thoughts about that?
Well, of course, there's the Medical Economic Index, which is an evaluation of the costs of providing care. That would certainly be a better index if we're going to use indexing.
Who prepares that index?
That is that from the CMS or the? Okay. I believe it is, okay, but I'm not positive.
I'm a new member, so please bear with me.
The other thing I was going to mention is that, you know, if we rebase, we're really not changing anything as far as the amount of money that we spend. We're spending the same amount of money. The only difference is that we're being honest about how much money we're spending. The previous system of going to the end of the year and then having this dance that we did every year is actually gimmickry. It's trying to pretend that we're spending less money than we are. So at least let's have some transparency and rebase and predict the true cost of the medical care that we're providing to our seniors and disabled. That's where we need to start. I would also say that there are a lot of imaginative and innovative ways that people are discussing about physician payment, and we're not opposed to any of them. We're interested in trying to find the right solution and the right way to do it, and we're hopeful that we'll be successful in that. But the first thing we have to do is rebase. That's absolute necessity, because otherwise it looks expensive to change the SGR when in truth it doesn't cost any more than if we didn't rebase. It's the same price that we're all paying.
Thank you. One of the things I've noticed over the years is the increasing complexity of the reimbursement process. And since we're talking specifically today about Medicare, I'd like to hear from Dr. Harris and also you, Mr. Hannon, from your standpoint, if you think that reducing that complexity, somehow streamlining the reimbursement process, might actually help deliver better health care and provide a better cost basis. Dr. Harris, we'll start with you.
As you know, we favor eliminating the SGR, but we feel that there's certainly a need, Congresswoman Kirkpatrick, for payment reform. Now, the model that is talked about most now is a patient-centered medical home. First, we would suggest that it be expanded from simply the 8 states to convert it from a demonstration project to a pilot project. It will be much more meaningful data if it involves far more than the 400 physicians that are anticipated to be involved. That's number one. Number two, that we need to explore other models. I mean, no one knows the answer to your question, how best to do this, but we need to get on with trying other ideas. So we would encourage this committee, we would hope that you would encourage that HHS would have the authority to test other models so we could see which accomplishes what you're after. Lastly, to the issue of simplifying things, everyone would applaud that. I mean, with hundreds of insurance companies, no two doing things similarly, it just takes enormous numbers of personnel just to keep this huge ship afloat. We believe that the patient-centered medical home, though, holds promise for simplifying that. And that if there is some component of reimbursements that's based upon bundling, as in for a team-based approach, where physicians are, and for the payers, they know that there is a bundle payment. They're not looking as much for calls for pre-certification or to justify because they don't really care. That would make it much easier.
I realize I've exceeded my time, Madam Chairman, so I welcome your response in writing. I don't want to take any more of the committee time, but again, thank you very, very much.